Good afternoon. My name is Amy Ross, RN, MSN, CPN, and this is my Kaplan audition. And I am auditioning to be an NCLEX instructor for Kaplan. I will give you a little bit of my background. I've been a nurse for 34 years, enjoying every single minute of it. I think I've worked for the entire 34 years, except for a few years when I was having children. I've taken care of patients from hospice care of the elderly to palliative hospice care of premature infants. I think what drew me to nursing was my love for giving and nurturing. I was the neighborhood babysitter. I was the first one to always run to somebody that was hurt on the soccer field. It's just instinctual. And I think nurses at their core are teachers. We teach every day. We don't have to be in the classroom to teach. We teach our patients. We teach novice nurses. I consider myself an expert, and I consider myself to be the content expert of pediatrics and OB. So people come to me for those questions, and hopefully I'll have those answers. If I don't, I know where to go to them. And I feel like I have so much to give in this realm. If it's not clinical, it's in the didactic realm, as I am now with teaching our future nurses out in the hospitals and in home care and in the outpatient realm. I just feel like I have so much still to give. So that's why I'm interested in doing this. So I have these questions that I'm going to go through one by one. I have 2 questions that you gave me as for audition. And the way I like to teach is I like to ask the students to try to eliminate the 2 questions that they think really are not the priority, or the 2 answers that are not the priority, and concentrate on 2 of the answers that could possibly be the right answer. So that really decreases their possibility from 25% to 50%. So that's kind of how I get them to think that the answer is right in front of them, that they need to critically think, that they need to look at it, they need to prioritize it, and they need to know what the question is answering and just answer that question. Don't think 10 minutes ahead, don't think 10 minutes behind, but answer what the question is asking. And that really, I feel when I say that to students, that seems to empower them more. So I'm going to go to the first question here. And the first question is, the nurse cares for a patient 4 hours after admission to the neuroscience unit due to a closed head injury. Which of the following is the most, as I said earlier, prioritize and use your clinical thinking, most important action for the nurse to take? 1, assess the pupil shape and reactivity. 2, take the patient's rectal temperature. 3, assess blood pressure and apical heart rate. 4, observe the patient's oxygen saturation level. What do you think is the most important? I ask them to also think the head of an adult patient is a closed head injury. When you have a child and you have an infant, their fontanelles close at 18 months. But the question is not saying that it's a baby or a fetus or an infant, it's saying the patient. So you have to infer that this is a closed head injury without any room at all for that brain to swell or anything, without any adverse reactions. So what are some of the things you think of that's going on inside the head? Pupils, blood pressure can change, temperature can change, saturation levels can change. But the most important is to assess the change in the pupil size or reactivity, which is an early sign of increased intracranial pressure. And you want to report this to the physician immediately. Likely, if you do see change in pupil sizes, it's because it's affecting the cranial nerve 3, which is the oculomotor cranial nerve, and it's the one that can assess and that can impact how your eyes open and close, your pupil restriction and constriction, and how your eyes are equal reactive and accommodating to light. Rectal temperature is important, but it's not a priority. Increased temperature is a late sign of increased ICP. So that's something that you would see farther down the line, not 4 hours afterwards. Early signs of ICP is changes in the pupils. The blood pressure is also an outcome that's not a priority, but it can be because vital sign changes are late signs of ICP. Observe the patient's oxygen saturation level. It's not a priority as CO2 levels rise with increased intracranial pressure. So carbon dioxide levels are very important to follow as they rise because the breathing gets more and more shallow. But the most important thing to follow is their pupil size. And I like to interject with some nice kind of, I like med comics. I don't know if you've ever heard of those, but my next slide is slide with increased ICP and what it looks like when students see a drawing or something like this that has some type of animation to it or something that they can actually look at that kind of grabs their attention, they tend to remember it more. You see changes in your level of consciousness. Here you go. Eyes, papilledema, pupillary changes, impaired eye movement, which again goes back to the compression of cranial nerve 3, which is the oculomotor cranial nerve, which can change how your pupils change, how your eyes change, and how they react. You have your posturing with your decerebrate and decorticate movements. You could have seizures, decreased motor function, changes in your vital signs with the Cushing's triad, with your increased blood pressure leading to decreased pulse and irregular respiratory patterns, which can be related to increased CO2 retention. Vomiting, changes in speech, and if you do have infants whose sutures do not close till they're about 18 months of age, you will see bulging fontanelles, cranial suture separation, increased head circumference, and a high-pitched cry, along with changes in, they could be vomiting, they could have seizures as well. So I think students really are drawn to these type of slides, and I really like to include them when I'm teaching certain things, depending on what they are. Depends on when I have the time, but I try to always put them in. The other thing I like to talk about is what do the changes in the pupils look like when you have ICP. This is pupils reacting equal and normally. The second one is pupils react to light, but they're slowly or briskly. That's a sign of increased ICP. Here you have a dilated pupil because you have the compression of cranial nerve 3. Again, it's going to change how the pupils react. This, when you have fixed pupils that are bilaterally dilated, of course, we know that that is an ominous sign. And pinpoint pupils is a sign that the pons, or at the very base of the skull and the base of the brain, is damaged or is from drugs. So those are the type of things I really like to have the students go through each question and prioritize as to which questions are or which answers are appropriate and which ones we can just throw away or eliminate. It's always easier, I have found. I have a very high success rate in my classes with teaching when I taught at Fortis and when I taught for precepting. And so I really feel that, and that's how I learn too, is that I eliminate the obvious and concentrate on the ones that I know are going to be part of the answer. The second question is, and this is all about prioritizing as well, the home health nurse plans a patient visit for the day. Which patient should the nurse see first? The 70-year-old diabetic with fasting blood glucose readings of 240 to 280 for 1 week, or 260 for 1 week. I ask the students, think about what is a normal fasting blood glucose reading. Then you have a 65-year-old discharged from the hospital 2 days ago following coronary bypass graft surgery. And that's all the question is saying. You're just doing a follow-up for a cardiac patient who had open heart surgery. You're going there to assess the wound. You're also going to assess the patient's cardiac functions. You have a 55-year-old with congestive heart failure who gained 3 pounds in the last 24 hours. And finally, a 40-year-old with metastatic breast cancer complaining of pain unrelieved by pain medication. Now, what that last question is saying, it's not saying that the patient is getting ready to pass, that the patient is in palliative care, that the patient is having pain that they can't even breathe through or talk through. The question or that particular answer is not stating that. It's so important. I tell these students, so important, don't read into anything. They've learned so much in their 4 years or their 2 years in nursing school, but don't read into every question. Look at each one of the choices and prioritize. So what do we think here? Do we think that, what do we know? Do we know that a normal fasting blood sugar is between 240 and 260? Yeah, it pretty much is. It's pretty much, that's a good fasting blood sugar. Are we going to go see the 65-year-old first that had 2 days ago following coronary bypass graft surgery that was discharged from the hospital? It's not saying that there's any infection. It's not saying that the wound is dehisced. It's not saying any of that. It's just stating the obvious that the patient was discharged 2 days ago. You have a 55-year-old with congestive heart failure who gained 3 pounds in the last 24 hours. Is that a priority? I would say yes. 3 pounds in the last 24 hours is usually number one on the discharge paperwork for that a physician gives the family before they leave the hospital, or the patient, that if you gain that much in 24 hours or 48 hours, please call the physician immediately. And finally, a 40-year-old with metastatic breast cancer. As I said earlier, this is not a priority. It's just saying that the patient's pain level is a little bit elevated. It's not saying that the pain level is a 10. It's not saying that the pain level is a 1. Read what the question is asking you. So let's go through the priorities. So the first one is the 70-year-old diabetic with a fasting blood glucose. It's not, the follow-up is required, but again, that's not a priority. What is going to take me to the priority would be the rapid weight gain that indicates fluid retention, which could exacerbate CHF. That's who you're going to see first. That would be the very first patient, because what could that be saying? That patient could have edema, dependent edema. It could exacerbate the CHF. They could have productive cough. They could have CO2 retention. They could have problems oxygenating. That's the patient I would see first, because that patient likely is one that you're going to have to spend the most time with, because you may have to talk about admitting the patient. You may have to give them an extra dose of diuretics. You may have to send them into the emergency room. I would take care of that patient first. That is prioritizing, and that is using your clinical judgment. And that is what the question is asking. It's not asking you any more than that. It's not giving you any more than that, which is why you need to concentrate on just the words in the answers. So your first patient would be the one with the congestive heart failure. Your second patient would be the diabetic with the fasting glucose of 240 to 260. Again, that's slightly higher, but it is fairly within normal. But this is a patient that we know how quickly diabetic ketoacidosis or hypoglycemia can happen. So that's the patient you would see second. The patient you would see third would be, you want to go in and check on that patient. That is, once you've taken care of the diabetic patient and made sure you've gone through their food diary, made sure you've gone through all of their meds that they're taking and all of their insulin doses, and be able to look at everything with their sliding scale and with all the information they've been able to accumulate over the week with their fasting blood sugars and their postprandial and when they take their blood sugars, be able to do some teaching with that. Your third patient would be your post-op patient. You would go there, assess the wound, see how it's doing, see if there's any drainage, look at the dressing, be able to talk to them about how they're feeling, whether their pain is under control, be able to talk to them about their post-op checkup. Those are the things you would do for that patient. And for the very last patient, who again you may have to spend a little bit more time with to make sure you're adjusting the meds appropriately, would be your patient with metastatic breast cancer complaining of pain unrelieved by current pain medication. Again, you may have to call the referring doctor to get an increase in the pain medication as well. All of these patients, too, should have follow-ups the next day as well. And I did include a slide about when to call the doctor for congestive or right-sided heart failure. Weight gain of 2 to 3 pounds in one day or 5 pounds in less than a week is the #1 priority of when to call the physician. That patient is likely having shortness of breath, probably swelling of the feet and legs, feeling full and hungry but unable to eat much because of probably the ascites and the hepatosplenomegaly that can happen from congestive heart failure and from right-sided heart failure. So that is why that type of patient is a priority. And then another one that I included was normal fasting blood sugars of 80 to 100, where those are normal levels. This is a little bit high, which is what we said is why you should see that patient second. 240 to 260 is considered high. So, but again, that patient, it's better to have a high blood sugar than a low blood sugar for sure. You want to have those blood sugars within the normal levels, but you want to make sure too that that patient does not need to be seen right away. That patient can be seen immediately after you see the patient that has the congestive heart failure. Because as I said earlier, you could be sending that patient to the hospital. You might be sending this patient to the emergency room or to the hospital as well, but you want to get to that patient with the congestive heart failure first. That is the end of my presentation. I hope this was to your liking. I am so looking forward to being a part of the team. I can travel, I can go wherever. This is what I love to do. I love sharing and I love being able to teach the next group of nurses coming up because I feel like that happened to me and I want to pay it forward as well. I'm very social. I love interacting. It just seems like a really good fit for me. So thank you so much for taking the time and I hope to hear from you soon. Bye-bye.